Oh, hello and good day. It's David Nabarro speaking to you today from Voltaire, just outside Geneva. And I'm greeting everybody for this open online briefing. As always, the way in which we like to work today is by offering you some observations on what's happening with regard to COVID-19 around the world. And then after that, some questions and answers, if you like. My focus today is, in the last briefing, on COVID in poor settings and some of the experiences we're hearing from around the world. I want to reflect on what I'm hearing from India, what I'm hearing from different parts of Africa, and also some of what I'm hearing from Latin America. And as I do so, I want all the time to be reflecting on what I'm learning, but also where I think things are going, in line with some reflections that we developed last weekend about the importance of anticipation, articulation, adaptation, and accountability. And I'm not going to try to actually sort of talk around those functions, but I want, during my conversation, to reflect on why those are important. And I hope that if we then, during the discussion, get a chance to talk about leadership styles, we can bring those points out. So first of all, a little bit about what I'm seeing around the world and hearing from different people who are working so hard. And let's go first of all to Mumbai in India. Mumbai is the capital of Maharashtra state, where they've had some quite serious outbreaks of COVID, and they work very hard indeed to contain the spread quickly with a combination of public health actions at the local level and at the same time a major restriction on movement, what we're calling more and more lockdown throughout the municipal area. And most of the challenge in Mumbai was because a lot of cases were being detected in parts of the city where people live very, very close to each other, what are sometimes called slums. And in these dense settlements, the process of interrupting transmission is particularly difficult. The first stage, of course, is to help people to identify when they're ill. That then is the absolute signal that they need to be isolated. But supposing you can't isolate in your home because your home is just one really small room. So then the whole family has to isolate. But again, in these very densely populated areas, individual families isolating is hard, and you instead have to actually isolate a whole section of the community. And in the municipality, they've referred to these areas where they feel that there is a lot of COVID being transmitted as containment zones. And they're very clear that what really matters is that people should not move out of these zones where there's thought to be a high level of virus transmission. Instead, they've got to stay in there until the transmission is reduced. But that has to be done with very great care, because as well as people staying in their transmission zones, there also has to be food provided, water provided, and people need to be able to have access to sanitation or latrines. And so that process of identifying containment zones and limiting movement out of containment zones while ensuring they're supported with all essential services and support has been what's been going on in Mumbai. Now, it's not enough just to actually contain the virus in one place by preventing movement out of an area. You've also got to do all the necessary work to reduce transmission. And there, it's about not only isolating people who've got the disease, but also finding those with whom they've been in contact in the recent past. That's not easy because you have to ask people to give details of what they've been doing in their personal lives. And so in the Mumbai setting, they've been having a large number of local health workers who have been repurposed from their other roles, and they've been asked to do the contact tracing work in these densely populated areas. And these are people who are truly heroic. I've read many accounts of the way in which they've had to actually get into the confidence of the people with whom they're talking. So I'm, say, talking to Deepak, who's got COVID, and I'm having to ask Deepak what he's been doing in the last few days since his symptoms developed, indeed just before his symptoms developed. And I am having to say, well, where did you go and who did you talk to? And Deepak's going to say, well, I can't tell you everything. I've forgotten a lot of it. And so what the contact tracers have to do is actually ask people to retrace the last few days of their lives and remember those with whom they were close to for a reasonable length of time. Just a passing contact, well, that probably is not important. But what really matters is the people that they've sat next to, perhaps next to them in a tea shop or something when getting some food, or next to them because they've been sitting with them at a meeting, and or at a shop. And you've got to try to find situations where there's been probably 10 or 15 minutes of close contact, because that's where the virus could have spread. And then the people with whom the case that you're talking about have been in close contact, well, they need to be identified and isolated and kept under surveillance as well. That's the hard part of interrupting transmission, but it's also the most important part. All the studies that I've ever looked at of infectious disease control have reminded me that it's that skill, not just at identifying cases and isolating them, but tracing contacts and getting them to isolate themselves. That's the key to interrupting transmission and suppressing outbreaks. And so in Mumbai, what they've been doing is really scaling up testing capacity throughout the municipality and trying to move it to the point where they can get results back really quickly within a day or two. And then that informs the people who are doing the case finding and contact tracing, because the whole effort of the corporation, the municipal corporation, is to try to work out where is the virus now. And because there's a lockdown in place, the virus is pretty well stuck in the places where it was before the lockdown started. You're not getting a huge increase in number of cases. And so the hospitals are not overflowing, but what they're trying to do now is to painstakingly work out exactly where is the virus, exactly who is infected, exactly who is transmitting to whom, so that gradually by isolating people with the disease, the outbreak will subside. And it's a tough thing to do because, as I say, the conditions aren't really very, very, very easy for isolation. The other thing I learned from the Mumbai experience is how they are being very careful to check to see that people who've got fever and who are feeling uncertain have got a call center that they can ring up where they will definitely get an answer, and then they will get medical advice back. I've watched how these call centers work. We had them during Ebola in West Africa. You get an awful lot of people ringing up and mucking around. You get quite a lot of calls which are really not relevant at all. And the requirements of the call center operators are enormous. They have to be very patient in dealing with calls that are nuisances. But at the same time, they have to be able to sift through and find the calls that are genuine. And the same is the case in many of the developing country experiences that I've seen recently, where call centers are being used, not just as a basis for people to get answers as to whether they've got the disease, but also to have a discussion about what the control measures mean for them and what their lives might be like. So this call center function is a very, very important way of connecting authorities with people. The other thing that I've picked up, last point, is just the real effort being made in Mumbai to protect health workers as much as possible. It's something that is the case now, I'll tell you in a minute, in Africa, but everywhere health workers are getting infected. And so trying to make sure that there is good quality protective equipment, if necessary, recycling it. It's not an impossible thing to do if you're very short supplied, and ensuring that wherever possible, health workers are not just protected, but are given real value by their communities. So this has all come from a contact of mine who is working in Mumbai and who's in charge of the municipality response, with whom I worked in the UN some time ago. And it's a reminder to me that when we're doing this kind of work, we depend enormously on the trusting relationships that we've built up in previous outbreaks and the experiences we've had together. And that sort of capacity to stick together and be a community of people who are learning with each other based on trust and respect is so important, and I'm learning about it more and more. And that brings me to focusing on some of what I'm hearing from colleagues with whom I used to work in the World Health Organization, now in Africa, and the real uncertainty that they still have. How serious is the virus when it gets into African countries? Is the age structure such that there's less mortality because there are fewer older people in the population? Or alternatively, are there challenges of many communities in Africa, particularly with difficulties of access to water and other such things, are those making spread more likely? So in some North African countries, particularly Algeria, there are reports of quite high levels of disease and also fatality. And there have also been a number of African countries, particularly in the West, which have also reported big numbers, and they're watching with great concern as to whether or not there is quite widespread virus spread. But what we're also seeing from many African countries is the existing habits of being able to work as a community in the face of threats are really being applied to the full. It's part of the resilience in many African societies that I saw when I was working on Ebola, that I've talked about in previous online briefings. And so there is this absolute sense that the community cohesiveness is working in many parts of the African continent. There is also a sense that perhaps there is not such severe outcomes in all locations from the disease. Concerns about access to testing always, concerns about access to running water and whether or not people can maintain hygiene, and concerns about whether or not people can get PPE, protective equipment, in health facilities. In South Africa, I hear as colleagues are trying to do everything possible to maintain the lockdown so that people who have the virus are not moving around and transmitting it to others. Many of the people who have the virus in South Africa can trace their virus, they believe, back to people who brought the virus into South Africa from other parts of the world, particularly Europe and North America. And so there is some hope that it would be possible to prevent the virus from moving into other populations, particularly those who've got high levels of HIV. So we are watching very carefully to see what happens. Perhaps one concern I'm hearing from many African colleagues is that with all the attention shifting to COVID in many health facilities and public health programs, then services for people who've got other conditions like malaria or like HIV or tuberculosis, and also services for maternal and child health, that they are suffering. And that's a story we hear from many other places too. And so we go to Latin America, and what we're hearing from colleagues in countries there, in Brazil particularly. And yes, the unfortunate situation is that we're hearing reports of quite large spreading of the virus in several different settings, including in favelas, and then increasing overload of health services with patients who need care, and anxieties about whether or not this is going to become more and more widespread, with some reports of indigenous communities being particularly susceptible. We spoke to colleagues in Australia, again, people we'd worked with before, recently, to find out their experience, and hearing about the challenges of cruise liners who want to try to dock and bring their passengers on board, and really facing a lot of opposition from local authorities saying, do not dock, but then saying, well, what are you going to do? Send over 1,000 passengers, with some of them with COVID, back onto the high seas and risk death? Are you going to make that happen? No, you've got to find a way to bring these people on board, to give them proper triage and treatment. And our colleague who was working on this with his colleagues in Australian authorities was describing the nature of the dialogue and the kind of negotiation. But he raised another point, which I really, it shows just how everything is linked together. He said, but you know, these cruise liners, they're also going to go to Pacific Islands, and they're not going now. but the people in Pacific Islands depends hugely on the income from cruise line passengers when they disembark at their ports, and they're a tremendous source of foreign exchange. And that's all drying up, and that echoed with what I've been hearing from so many other poor countries, that those that have orientated their economies towards tourism are finding that the tourist income has just dried up, and they've got huge numbers of people in the formal economy, but also in the informal economy who are really, really short of cash. And so, as well as looking at what COVID itself is doing in poor countries, we have to also bear in mind that the containment measures are having a big impact on local populations, with hunger and malnutrition on the rise because people can't get the food they need. But we're also hearing accounts of the economic impact because of the breakdown in international travel and tourism, with many countries right in the middle of peak tourist season, just also having to cope with the fact that employment has declined. And so what you see is this chain reaction of interconnected problems occurring, starting from the COVID. And that's why this focus on anticipation, trying to be prepared in advance for possible impacts of the COVID outbreak that go beyond the disease itself, is becoming so important, and why many of the people with whom I'm working are looking at those cascading impacts and anticipating them in order to try to take rapid action. So that brings me now further on with looking at what's happening in poorer settings to the agriculture and food situation, which I wanted to just make a special point of talking about. So I've said before that we were really concerned about the access to food and nutrition for poorer people. And so here's an account that I had yesterday from a colleague who was talking about the food situation. So in a crowded area where she is living and working, she said the way in which food distribution is done is that a truck arrives with sacks of food and it stops. And there are obviously police there trying to control the crowds. But the immediate consequence is a huge fight, as a lot of men just go in there and try to get whatever food they can, and they attack the guards and they push them aside. And of course, the guards try to maintain law and order, but it's really difficult, and you don't want to have shooting in these situations. So essentially, getting the food is just a scrum. And it's really, if it's perishable food, the food gets damaged in the fighting. If it's non-perishable food, there's just a lot of blood and everything, because people are just going crazy trying to get food. And women tell me, we just can't go into that. We would just get knocked aside, and we try. But often we have to really depend on the men, and the men may not always give us the food we need, and we've got real worries about our children. So there's a real challenge at food distribution sites about ensuring that women and children get access. And it's nobody's fault. We've just seen this time and time and time again. When you've got a trunk full of food arriving in a place where people are hungry, it's super hard to maintain law and order. And you can try, when you're handing it out, you can try to have special distribution for people who are less easily able to fight, but it requires a very, very large organization, and it can get very difficult. So the food side and helping people who need food to get it is difficult. Yes, one of the alternatives is putting cash into people's cell phone bank accounts, much, much safer than handing out cash, because you usually get robberies when cash is handed out, unless you're very lucky. And so the use of cell phone banking has become hugely important. We're hearing from lots of countries in different parts of the world, particularly from our friends working in Morocco, but we're connected with other countries, that there's been a very rapid effort in the last 2 or 3 weeks to really build up cell phone banking in many places, so that money can be got into people's cell phone bank accounts so they can get the food they need. But then we go to the other end, something we were focusing on yesterday. Who's looking after the farmers? So we've got now reports. We can't put numbers on it, but all I can say is very large numbers of farmers all over Asia, Africa, and Latin America, and indeed in Europe, who are just saying, we are in difficulty. Our markets for our produce have just really tumbled. We are not able to sell our fresh goods, our milk, our eggs, Even our meat is proving to be difficult. And also we're having difficulty with selling our fruits and vegetables. And they're saying we're having to let them go rotten and plow them back in because we just have got no market for them. We are suffering from a real decrease in our cash income. We're having to go to banks and ask for extra loans, and we're already in debt. And this is affecting, actually, I believe, hundreds of millions of farmers all over the world, particularly what we call smallholder farmers. And we've seen that when smallholder farmers get into distress, particularly when their indebtedness increases, they get very upset. And we've got absolutely clear evidence that this is a direct precursor of suicide. This happens in all nations. It's reported from the United States, it's reported from India. In Africa, it's not suicide, but according to my friends, they just say farmers get really depressed and upset and angry. So one of the things we're doing now, and it's really just connecting people together. We're trying to help farmers to find ways to connect better with urban consumers and indeed encourage urban populations to come and pick up food from their farms, to pay them a bit rather than have the food go rotten and get it to urban areas, particularly nourishing food like fruits and vegetables. It's a small thing, but it's showing that actually if it's possible to short circuit some supply chains and make them more local, that can actually be really helpful. And so that aligns with one other thing that I was hearing from my colleagues in Médecins Sans Frontières. This is the international organization that always provides medical care whenever it can to people in need around the world. And they were working in Bergamo in northern Italy a few weeks ago and helping Italian colleagues who had not run emergency hospitals, some of the techniques that they'd learned from emergency hospitals to deal with cholera or Ebola around the world. And I was saying to my friend Brice in Médecins Sans Frontières when we were discussing things, you know, what are you really finding about the situation now in poor countries? He said there's one thing that we've learned, and that is that you can't really expect poor countries to just wait at the end of the queue for protective equipment for their health workers or for their masks or other essential items, because it's just not coming through. Although we are doing everything possible to try through the World Health Organization and other wonderful schemes to protect this special equipment for health workers in poor countries. But I mean, the reality is that we get messages from health workers in Britain or in the US, not just health workers in hospitals, but health workers who are providing healthcare in residential care settings. They're saying we haven't got the protective equipment we need. We're struggling with masks. We're struggling with the visors. We're struggling with the necessary protective equipment to ensure that our bodies are protected. And so we're not surprised that in poor countries it's not getting through. Quite simply, this stuff is scarce, scarce, scarce. And the reason why it's scarce, they tell me, is that everybody knows that this virus isn't going to go away. It's here to stay. And so that means that every hospital is doing its best to stockpile protective equipment and masks and all the rest, not so much for dealing with the current big upsurge in outbreaks, but with the outbreaks that are going to come in the future, because the virus is still going to keep coming back. It's still going to be a problem. So health workers all over the world are at short supply, but particularly the health workers in poor countries. So back to Médecins Sans Frontières, Brice, he says to me, the one thing we've learned is we've got to help communities and nations be as self-sufficient as they can on everything that matters in healthcare. And he said, look, actually ventilators is not the most important thing. The most important thing is to try to get oxygen, because what really matters when people get badly ill with COVID is if they get short of oxygen, and it's what's called a silent hypoxia. They actually don't know that they're short of oxygen. They're still doing text messages and things. Then suddenly their body says, uh-oh, my oxygen's not enough. And there's a sudden decline. And immediately it's, oh, got to get this patient to hospital, quick, 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 quick. But it's then touch and go, because if you get to hospital when you've really got to that end stage and you're on the ventilator and it's trying to pump the air in to keep your air going into your lungs, and your lungs are not feeling very good at all, that's too late. And so much of what's being learnt, said Brice of Médecins Sans Frontières, is early care is what really matters. Try not to wait till everything's really bad. And then relatively small number of interventions, but particularly helping people to breathe can avoid things going wrong. So he said, we're trying to work on local techniques to help do this good quality care early. And then he also said, we're helping people develop their own PPE, to make their own masks and to get their own protection right, because they're finding that just waiting for stuff to come from abroad, they end up having to pay over the odds. And he said, we know that that means that they probably won't be able to do testing, but we're helping them to try to work out how to deal with the COVID without tests. And I suppose that's what I'm really learning. And that's the purpose of this briefing today, that as I go around the world, not obviously literally, but figuratively through wonderful things like Zoom and the mobile telephone, I am hearing of all sorts of ingenuity and action as people are working out how to deal with COVID now. Now, just a couple of words of coming out of lockdown. Of course, it's taken us, I think, an awful long time. And when I say us, I mean the public health community, to get the message across that this virus is here to stay. It's not going away for the foreseeable future. And of course, if a vaccine comes along and everybody has the vaccine and it works, then we will breathe a great sigh of relief and be able to say, good, we can now go back to life without the threat of COVID. And there's lots of suggestions that the vaccine might be coming at warp speed, but I'm being really quite cautious, at least in public and actually privately, saying, and we just don't know how quickly the vaccine is going to come. So let's just be realistic about it. We're going to have to live with the threat of COVID for the foreseeable future. And so talking to colleagues everywhere, here's the kind of conversation I'm having, particularly with politicians. How long is it before we can come out of lockdown? You know, some countries are doing 4 weeks, some countries are doing 6 weeks. Is there a sort of time? And does the shape of the outbreak curve, is that's what should be driving our decision to come out of lockdown? And I listen, and of course I want to answer saying, yeah, there's a formula. When your curve is plateaued and you've not got any more cases on your testing for 2 or 3 weeks, then you should be able to come out of lockdown. Or when your intensive care units throughout the country are all with only 1/3 of beds full, then you can come out of lockdown. But it's just not like that. It's not like that, because what really matters is that societies everywhere have to be in a position to defend themselves against new outbreaks of COVID as they build up, sometimes almost silently. And then they have to be able to contain outbreaks when they get big, quickly, with quite a dramatic response, a kind and dignified response, yes, please, but it's got to be firm. A little bit what I was describing in Mumbai at the beginning. It's got to be firm, because you don't want people coming out of a place where there's a lot of transmission. As a colleague said to me this morning, refer to them as hot places. You don't want people coming out of the hot places and taking the virus to other places, because you want to contain the outbreak where it is, and you want to suppress it where it is, because you want to keep the virus at bay. As my friend Lothar in Germany was saying about the German response, he said, we've had success, but we've got to defend our success. Getting ahead of the virus is being able to defend against it coming back and causing big outbreaks. And of course, you know that it will come back sometimes. It'll breach those defenses, not least because there'll be some people who carry the virus without showing it. And so you're saying, yes, please, if you've got the symptoms, stay at home. But there are some people who feel right as rain and they're still wanting to actually move around. So you've got to actually have that capacity to deal with new outbreaks that might suddenly brew up without seeing it as a failure. It's part of your containment strategy. So it's what's happening in Germany right now, because they have started to release their lockdown and movement has started. And of course, the virus is coming out of hiding. It itself has been hiding in people, and it's coming out, and transmission is starting up again. And there are places where there's quite intense transmission. So as part of their defending their success, they've got to be able to react quickly when there are new outbreaks. And that is in itself a good response. It doesn't mean failure. And so in Singapore, as I've told you a few times before, hearing from colleagues there, they have got virus in some of their worker dormitories, but they are dealing with it, and dealing with it as part of their successful containment strategy. And we'll need to have that discussion, I think, in every community, everywhere, including, of course, in countries where there is agonizing about what's the right way to to scale and to do a release from lockdown, we've got to be able to say releasing from lockdown includes being ready to respond quickly when you get first signs of a new outbreak developing, especially if it's not proved possible to deal with it right at the beginning by finding the individual or the household or the chain of transmission. But suddenly you've got in a particular town a number of cases emerging. And what do? You stop people coming out of that place. It will drive them mad and it will make businesses upset, but they will know that that is part of the price you have to pay to keep the rest of the economy going. Is if you've got a hot area, you basically stop movement out of that area. That is the secret. I keep saying to people, it's movement out that matters, not movement in. It's movement out. Stop it coming out and then gradually deflate the outbreak where it is by doing the necessary case finding, contact tracing, isolation, and of course get the care services right, but make sure they're working really well. And when you do these what I will call now revised or limited movement restrictions and lockdowns as part of your containment strategy, at the same time have a protocol saying, how do we make sure that the people who are poorest, the people who are most in need, the households which have got a single parent, places where we know there's a history of domestic violence, the places where there are potential problems, making certain there are good protocols for ensuring that services continue. And that includes ensuring that basic health services go on, that women can access reproductive health care, that people who've got chronic diseases continue to receive treatment. It's that kind of sophistication of learning how to deal with the necessity of intermittent lockdowns, whilst at the same time maintaining essential services, protecting people who've got special needs of all kinds. That's going to be the pattern for the future. I hope there won't have to be a lot of it. But I keep saying, last point now, this virus must never be underestimated. This virus must never be treated lightly. This is a virus that came into the world suddenly 4 months ago and has been causing us a lot of anxiety and grief ever since. And we must take it seriously. We must treat it so seriously. And that's why I kind of was rather pleased yesterday listening to Tedros and the team in WHO, just being very clear with everybody what they've advised over the weeks, what they continue to advise, and what they're going to go on advising, that we've got to learn to live with this virus. We've got to learn to adapt our lives to live with this virus. It doesn't mean stopping everything for the foreseeable future, but it does mean working together, all sections of society, on how we can learn to live with this virus as a constant threat and keep it at bay. So I hope this rather kaleidoscopic introduction today, talking a bit about what I'm seeing in different poor communities, talking about the food and farming situation, and talking about coming out of lockdown, referring to what I consider to be a strategy where you expect there to be occasional resurgences. That's part of your emergence from lockdown. It's part of defending your success. I hope that resonated and had meaning. The toughest thing when doing webinars using Zoom is that you have to look at the camera. And if you think when you're looking at somebody's image that you're actually looking at them, that's of course not true. And we're so used to looking at each other during face-to-face meetings. It's quite bizarre getting used to this thing and not being able to see what I'm reading in your faces, your eyes as I'm talking. So let's see how it goes and give us some of your comments while we're talking. As a team in 4SD, we love doing these open online briefings. We love also developing our narratives and reflections. And we're really pleased with some of the thinking that's come together on our reflections about coming out of lockdown, the economics that this implies, where we were talking a lot with friends from a big NGO yesterday about what are the economic realities that are just going to be so important for approaching poverty. And we love focusing on the kind of leadership skills that are needed in this time because of our work in 4SD as a systems leadership mentoring service. So I'd like once again to just introduce to our team who are on this call. Most of them, some are doing one or two other things, but they're here and you'll see them if you're looking at your screen. John Atkinson is our systems leadership guru, and he's been working very much on leadership skills and kind of acting as a meta commentator really on what's going on while being a practitioner as well. Thuy Nguyen is our comms advisor. We've been having a lot of fun recently with this video that was produced by Derek Owen and his colleagues as a kind of crowdsourcing event from around the world, as well as we discussed in the last briefing, work being done by Nazim and Vicky Doyle on a song based on some of our narratives. So Thuy has been very much involved in the comms end of things and is very keen to connect with anybody who's got ideas for furthering the messages that we try to give out through our different media. Catherine Deland is our health advisor and has been making all sorts of connections to help us tune into different health actors. She's recently been telling us, and I forgot to say this, about some of the things that we're seeing from Indigenous communities as they stay strong in the face of this threat. Indigenous communities know very well that historically they've been threatened by disease outbreaks. We've got here, I've got the questions here, Flo. We've got also Joe Colombano. Joe, real specialist in the sustainable development agenda and an economist. And Joe has been working very intimately now on what responding to COVID means when you look at it through the lens of the 2030 Agenda for Sustainable Development. And I know some of you have been interested in that, and that stimulated Joe to do this work. Magali Mahdi connects with an NGO community a lot and is handling the quite challenging aspect of our schedule, especially as that where there are more needs than what we can do. And by the way, what Magali is doing is encouraging us at all times to network with others so we can get the message more widely. Sabir Moumen, who is our administrator, he's from Tunisia, and I've said before how he is pulling all that Maghreb community into our thinking more and more. Julian Delimontex, who is the mayor or part of the mayoral team, I'm never quite sure what role he is, in Flenia here, and who's been really helpful because of his experience of working in businesses, in helping us to link up with businesses who are the fabric of society, frankly, in so much of the future. And Florence Lesbenz, our managing director, on My Wife, who is helping us to hold the whole operation together. We do believe that continuing to interpret the guidance from the World Health Organization and share experiences from around the world is a useful service that we can provide. And we have people here from Philippines. Welcome to you. We are so impressed by what we're seeing from Philippines. And Joseph, it's lovely to see you. I think you're outside. If you want to say anything a little bit later, I might just ask you. We'll just see whether or not we've got time. But it's good to see you, Joseph. You're looking well. Thank you very much for joining us. You've got a good internet connection. That's good as well. We've got friends from the UK, of course, from a number of different places, some of whom we know. We've got Stephanie Okoyo on. I think, Stephanie, I don't know where you are, but it's great that you're here. Perhaps you're in Kenya. We've got people from the US joining us. Thank you very much indeed. Hello to you, and a big shout out to colleagues from the United States. Many from France, thank you very much. Lena, it's nice to see you here. So good that you've joined us, and others also from this part. Got Peter Scott Bowden from the World Food Programme. Pete, it's great what the WFP is doing in the getting essential supplies, but also responding to the hunger emergency and the nutrition emergency. And so also from other parts just with us and on, thank you. I want to give a special shout out to Marianne. Thank you indeed for being here. I can see you, I'm looking at you, and thanks again for all you have been doing and are doing and continue to do. Sarah Phillips, you join us quite often, and it's nice to see you smile. I hope that you find this useful. And if we can be any help, please send us an email or something to contact@4sd.info. We want to make sure that we can provide you with stuff that you can then take into your own networks and broadcast. We reckon we connect through these means with 3,000 or 4,000 people a week. And if each of those is connecting with their own networks, then we're able to continue the conversation about ways in which we can come to terms with things. I have been a bit slow in this middle portion. I'm sorry for that. It's partly a reflection of my mood, which is being very positive about the team and the fellowship that we have. First question. So Joseph, if I come to you, I'll try and be quick. It'll be in about 20 minutes. And so 15, 20 minutes. So, and it will be just for a short remark from you on what's happening in Philippines, if you feel like it. My first question, there seems to be some evidence that children are more at risk than people first thought. With schools opening up, can I speak to the risk for both kids and their parents? Should we be worried about asymptomatic children? So yes, research published recently has said that, and it's in the Lancet journal, that perhaps children are carrying the virus. They're not resistant to infection, and that means that they may be not only themselves with the virus, but they may be capable of passing it on to adults. That's the kind of information that when it comes along just knocks us sideways, because it really affects our feeling about what are the right strategies for releasing from lockdown. And it had been a hope that children going back to school first could then be a sign that societies were starting to get going again. But if it's true that children are not just able to get the virus, but are able to pass it to their parents, this will affect that strategy. Can I just make one point? There is no clear guidelines for coming out of lockdown. We've never had a situation before where half the world is living under some conditions of lockdown. There are so many known unknowns and unknown unknowns about this virus and its behavior. So coming out of lockdown is essentially going to be one massive experiment. I would love it if it could be done in a very controlled way with different nations saying we're all going to try different tactics and then we're going to compare results, but the world isn't like that. It'll be quite messy inevitably. But yes, I think what I want people to do is, I don't think we can afford to allow our individual worries to become so great that they paralyze us when it comes to moving forward. Instead, we've got to take the evidence. We've got to ask our friends in WHO and other places to weigh it up against other evidence. And then we've got to actually act, and we've got to see what happens and accept that it will contain some difficulties, but there's no actually perfect way to come out of lockdown. I'm quoting here Mike Ryan, the head of the emergencies program at WHO, who keeps saying to me, don't let the perfect be the enemy of the good. And we're all going to have to take some risks, but we'll have to take them together in a very eyes open way. So yeah, I read that and I thought, whoops. But at the same time, I think that we are going to have to just have a go. And there are two things that I want to happen. One is we've got to stop the isolation of children and keeping them out of school as soon as possible. I think that we're not fully able to compute what impact that will have on their later lives. And secondly, we've got to make sure that any shielding of people over 70 or whatever age we're going to choose does not isolate them completely from the rest of their families. Question 2, with so much information coming available, thousands of papers per week, how are you personally sifting through the medical research and validating or disconfirming new developments, like kids more at risk than we thought, or loss of smell of taste as an initial signal of infection? I just want to be very clear here that this is where I really value the World Health Organization. I'm not talking about the politics between the countries that run the World Health Organization. I'm talking about the fact that this is the place where there are people who are just doing nothing else except looking at data from published papers, comparing it with studies that have come from elsewhere and trying to reach judgment. And they don't work in isolation. They have huge networks all over the world of academics and others. And because a lot of the papers that are being produced at the moment have not been peer reviewed so as to get rapid circulation, and they often get headlines in the newspapers before they've been discussed by professionals, inevitably there's a kind of uncertainty. But I'm really, really pleased that we have got access to friends in WHO who are able to give us some kind of assessment. They're not always available, and because today is the big meeting of the emergency committee, its third meeting since COVID began, the usual discussion we have between experts from around the world has been postponed, so it's a little bit frustrating. But yeah, these are things that we check up on regularly. And you're quite right, sifting is hard. Question 3, we're hearing that drugs like remdesivir, this is a drug produced by a company called Gilead in the US, are now available that can treat COVID-19. What's the latest understanding? When you get a new drug, you have to do controlled studies where you test the drug against people who've not got the drug. Ideally, they are randomized, but we can't always have randomized, i.e. people allocated to treatment or placebo without the patient knowing or without the investigator knowing. It's quite difficult to do randomization in an emergency, but at least you've got to have controls. And you've got to pull together the results from controls and compare them. And that's what the solidarity trial system in WHO is doing. And the remdesivir trials that are going on are part of solidarity trials. But of course, people are super eager to get results. So you get the early results sometimes produced from a part of the study before the whole lot has been done. So yeah, I've heard that there are some cautiously optimistic signs. And Tony Fauci, who's the communicable disease guy in the US, has gone on record overnight as saying these are promising signs. But I say to everybody, please wait for the results to come through. There are all sorts of people pushing either their own favorite remedies or hopeful remedies, but we are not yet at the stage where we can say that remdesivir or any other drug or drug combination is proven to have a curative impact on this thing. And I am well aware that there's huge pressure, and a lot of people who've got relatives who've got COVID are desperately trying to get hold of the drug. So I'm well aware that this is a tricky one, but my line is, this, like everything, is promising, but we must wait till the full trial is completed. And that brings me to question 4. Vaccine trials seem to be positive in the UK, US, and other places. Do they work, and how soon will vaccines be widely used? Answer, candidate vaccines are here. Human studies are being done. You move from volunteer humans to populations of humans to then much bigger populations of humans on thousands of subjects. Then you go through the licensing process where files are given to the licensors. There'll be huge pressures on the licensors to grant what's called emergency exemption from some of the detailed testing. People like me will say, whatever the urgency, make sure it's safe, make sure it's effective. You do not want to have a problem of a vaccine that causes complications or a vaccine that seems to not be fully effective. So I think it's 18 months, even though we've got candidates now. I know people are talking about the end of the year or early next year. I think it's probably 18 months, i.e. mid to late 2021, before this is going to really be moving on. And this is from Joseph Batak, who's here on my screen from the Philippines. Joseph Batak, like me, is a smiling senior citizen on day 47 of a 24-hour lockdown. Most of the fatalities are older people. Most of the infection is mild. Older people in villages like mine have their immune systems boosted by mild infection, so there's a herd immunity for senior citizens. Joseph, thank you for that question. I continue to hope that it will turn out that a lot of people will get mild COVID, be immune to getting the disease again. That will then mean that they are not only able to to have a less likelihood of a big COVID outbreak in that community. There's just one problem, and that is we don't know whether or not having COVID once gives you full immunity against a repeat infection. Joseph, I see you nodding through the corner of my left eye. And so this question of and how powerful the immunity is after infection or after immunization is a big one. It's one of the known unknowns, but I am really hopeful it will turn out that having had the virus will make you immune. That will have a beautiful mean that you don't have to worry about moving around. You don't have to shield yourself. And this will be very important for reducing any social isolation of senior citizens. So thank you, Joseph. Joseph, I'm just going to ask you, can you just unmute for 1 second and just, I've unmuted you, just if you want to, just say good day to the Philippines.
Hi, David. Can you hear me?
Well, it's
yes.
nice
Okay. Just to be quick, I'm looking at a way not to wait for 18 months before any vaccine will be made available. And so I'm trying to establish a community-based COVID herd immunity type for senior citizens. And that's where my mind is going right now. Thank you for having this platform. This is very helpful.
Joseph, thank you for telling us. We will stay in close contact with you. We'll ask you to maybe we can connect with you by email or WhatsApp and hear your. Now I know what you're trying to do. I will also share with colleagues and I will say, there is Joseph. He's trying this experiment and let's keep in touch with him and hear his results. And just everybody, thank you, Joseph. I'm really grateful to you for saying a few words. Lovely. And I just wanted to say to everybody that this is a global simultaneous experiment in behavior change, in immunology, and in finding ways to work together to be strong in the face of this threat. And this is proving to me the strength of the human spirit. We're all together in this, connected by one objective only, and that is for health, equitable health in the face of a new threat. And question 5. There's a little bit more on the herd immunity. My query on putting up a herd immunity is that this is a bottom-up rather than the predominant top-down actions like lockdowns. I just want to say, absolutely. I don't know if there's any other way of my looking at you, slightly with tears in my eyes. This is so important. You know, a lockdown or a regulation from a government or even some kind of control from authorities is merely a means to enable us, members of the human family, to find ways ourselves to live with this threat. Just as we found ways to live, as I've said many times before, with the threats posed by HIV, so that we could go on loving and being intimate with a virus in our midst, we're learning to do it. We continue to learn to do it. Harder for some than for others. So let me not pretend that it's been a total unqualified success, but it has been a collective action by humanity. And we're going to have to do the same with this. And we'll have to do the same with other threats as they come along. So thank you. Bottom up, if you don't mind that term, or community up, that's the way to go. And sharing experiences of what I would like us and all of you to do. The more we share and connect, the better. Question 6, referred at times to different aspects of the impact of COVID-19 on women and girls, whether it's gender-based violence, discrimination against women health workers, problems with getting access to food. What coordinated action is there to look at the impact of the pandemic on them to address their needs? Of course, there are organizations that are speaking up for women. We work closely with a wonderful organization called Women Deliver, and we work closely with the UN Women Program. And then our friend Winnie Byanyima is head of UN AIDS and has recently been talking about the fact that women are really in difficulty at the moment as a result of COVID. But frankly, the people who have to focus on this are men who are disempowering women, and they've got to leave space, an opportunity for women to be able to show individually and collectively that they have an awful lot to offer on dealing with a challenge like this. I sometimes refer to it as feminine leadership styles. I don't mean that that's a woman leadership style. I mean, it's a leadership style that actually focuses primarily on cooperation, sharing, learning, participation, inclusion, rather than exclusion, dominance, and credit taking, which seems to be more of a masculine leadership style. I don't wish to cast any aspersions that are doing gender stereotyping. I am just talking about styles of leadership. And I believe that what I've learned over time from, for example, the women-led peace movements in Liberia, led by Lima Gabawi and others. They've shown me that if you can make sure there is space for women to be able to show what is happening and to be able to demonstrate that if they are given opportunities to act on things like making ourselves sufficient, things like access to food, things like ensuring that children are not omitted from all the issues in the response, then the world will be a lot better place. So yes, there's coordinated action, but there are real challenges. And we've been talking with our friend Sarah Hawkes, who works particularly on gender disaggregated data. She says, look, more men are dying, but at the same time, more women are being impacted by containment measures. We need this gender disaggregated data all the time. And I think that's so correct. And we do need to continue advocacy and support for coordinated action through networks. And if any of you have got stories of where women have been able to really take on and show, we have a great member of our 4ST team called Yvonne Otieno, who is a fruit farmer and fruit dryer and packer in Machakos, just outside Kenya, who brings us about every week or 2 weeks to explain what she and other women in her community are doing. And I keep wishing, I want to interview her. I want to write her story. I would like to put that out on any of the reflections we can. It's always just a slight shortage of time. So any stories you can give us, or if anybody wants to interview women and we can invite women to be interviewed by you over WhatsApp, and then you don't mind transcribing their stories, anything like that to get the stories out would be really, really great. Sorry, that was an excessive repetition. Question 7, only 4 minutes. European countries are beginning to move towards opening. Are countries in the region establishing the necessary testing and tracing systems to deal with resurgent outbreaks? In other words, are there countries that are COVID ready? I like to talk about Austria, Germany, and Denmark. I particularly like Germany only because I keep following the words of Lothar Wieler of the Robert Koch Institute. And I said before, he was talking about defending our success. He was talking about the inevitability of needing to deal with resurgent outbreaks. I am very impressed. But then my colleague Bruce Aylward has been in Spain, and he's been talking a lot to the Prime Minister, Deputy Prime Minister. He's been trying to put himself into their heads, trying to help them anticipate. They really want to reopen parts of tourism industry in Spain. They also are worried about agriculture. And he's just been saying again and again in dialogue with them, okay, it's a bit of a balance of risks. Of course, you're going to get resurgent outbreaks, but you need to be ready to deal with them. And of course, you're going to still have COVID, but you need to have the defenses in place. And you just have to balance up. Does it look as though you've got things under control enough in your judgment to release the lockdown, let some of the hotels reopen, let some of the other things get going, whilst at the same time being defended? So I'm really, really interested in the way in which there begins to be much better articulation by politicians with the public. Spain's story is really good on this, so that they're explaining, yes, there's a balance of risk. Yes, we can open, but there will be new outbreaks. Okay, so will you accept that? Yes, of course, we know from the unions you will. So therefore we will do it. And we will protect the health workers. We don't want the health workers dying. Managing exceptions, no question 8, is key in crises. Getting clear information out, what measures should countries put in place regarding vaccine availability, even if it's 18 months out. I want transparency. I want clear articulation, because unless we're any good on this, we won't be able to get public on side. Now to the very end. Dr. Iman Ahmad, a Canadian who's in lockdown in Cairo, Egypt. I've been working with Maha Rabat, the former Minister of Health in Egypt. She is telling me some really powerful stories. Here's what Iman says. Thanks for validating the points from MSF on oxygen, local production of protective gear. It speaks to our direction to support Sudan. Sudanese doctors abroad have come together and prioritizing our interventions on a daily basis. Iman, thank you. I'm close friends to Naima Al-Kabir, the WHO representative in Sudan. I will connect with her. You have given me a very inspiring message. There is stuff on the Médecins Sans Frontières website If you want, I can point you to that if you can't find it on some of these issues. Please use it. It is really important. Everybody, it's the time. I want to really thank you. This for me has been great because I feel connected to many of you, partly by seeing your faces, partly because you've given us your names as we've done the questions. It is great. Can we please continue? Please keep joining. Please invite your friends and colleagues to join if they want to, or send them details so they can download these. Twee very carefully is loading them up on the website. Please keep connecting and commenting. The only way as humanity we can live with this stuff is by connecting, is by being strong, is by sharing. Thank you for all you're doing and for your inspiration. Till next time.